Welcome and thank you for joining the first webinar in NASTAD's three-part webinar series titled Scaling Up HIV Workforce Capacity for Ending the HIV Epidemic. This series will provide an overview of HIV workforce needs and challenges of health departments and their community partners, and will attempt to address some of those challenges and needs. In this first webinar, The State of the HIV Workforce, presenters will provide an overview of HIV workforce challenges as we adapt to the new normal of COVID-19, practical steps for assessing and defining the HIV workforce, and a concrete example of an HIV workforce assessment conducted by an EHE jurisdiction. This webinar will be recorded and posted for future access. We encourage you to use the chat function for any questions or comments. We hope to have enough time to answer questions after the presentations. If we are short on time, we will compile the questions and send them out with the recording. Before we get started, Maria E. Alvarez from CDC will say a few words. Maria?
Thank you. Thank you for the introduction. Good day, partners. My name is Maria E. Alvarez, and on behalf of CDC's Division of HIV/AIDS Prevention Program Branch, it's my humble privilege as the Capacity Building and Technical Assistance Lead to welcome you all to today's webinar. Thank you for joining us today. We really appreciate you taking time out to attend. CDC is pleased once again to collaborate with NASDAQ to commence our next three-part technical assistance webinar series, Scaling Up HIV Workforce Capacity for Ending the HIV Epidemic. The TA series, as mentioned, will focus on addressing the needs and challenges faced by health departments and community partners as they work to implement their EHE plans. The series will also highlight the importance of community representation in the HIV workforce. Thank you also in advance to all of today's presenters. We are confident this will be another outstanding webinar and TA series forthcoming. A special thank you to NASDAQ for their ongoing efforts in planning and hosting our state-of-the-art webinars to the HIV prevention workforce partners and communities. If you have missed any of the past TA webinars, please visit NASDAQ's website to access recordings and slide decks. CDC remains committed to our ongoing partnerships and the provision of technical assistance services. Thank you again for your participation in today's webinar and for your active efforts to end the HIV epidemic together. NASDAQ, back to you.
Thank you, Maria. Next slide, please. Our first presenter today is Emily McCloskey, Director of Policy and Legislative Affairs at NASDAQ. Emily?
Thank you, Krupa. Thanks so much for having me here today. Next slide, please. Today I'm going to be talking about the impact of the COVID-19 pandemic on the HIV workforce. NASDAQ has conducted 3 requests for informations that were fielded across the Prevention Hepatitis and Ryan White HIV/AIDS Program Part B and AIDS Drug Assistance Program Health Department staff since the beginning of the COVID-19 pandemic. These were done in May of 2020, August of 2020, and March of 2021. Today I'm going to be talking about the March of 2021 RFI and the results that came out of that. Overall, we found that HIV and hepatitis capacity has been impacted across all programs as staff have been detailed to the COVID-19 response. Programs have struggled with continuity of care, but many have implemented innovative and adaptive strategies. While most programs don't anticipate cost containment measures in 2021, NASDAQ has experienced increased cost containment technical assistance requests, mostly focused on prevention of having to institute cost containment measures. And then ending the HIV epidemic activities have continued, but with anticipated delays and work plan modifications. Next slide, please. So the biggest impacts of the COVID-19 pandemic on the HIV prevention programs were really focused on decreased health department capacity due to detailing of health department staff to the COVID-19 response, as well as decreased program services such as outreach and education, testing and linkage to care, or case investigation due to social distancing and other COVID-19 related concerns. Just as a note, people were allowed to choose more than one things that they've had, or they're asked to choose the 3 largest impacts. So that is why these numbers don't necessarily add up to 100%. You can see that also we saw reduced capacity of clinical partners that provide services, as well as reduced capacity of community-based service providers. Next slide, please. The biggest impacts of the COVID-19 pandemic on the Ryan White Part B and ADAP programs, and I included this even though we are focused on HIV prevention because we know that the continuum of care is incredibly important. But here we also see that the detailing of health department staff to the COVID-19 response was pretty significant, as was decreased program enrollment, utilization, and retention due to social distancing or other COVID-19 related concerns. Next slide, please. Oh, next slide. Sorry about that. We do anticipate that that we are going to release another RFI for states to learn sort of where we are as states have really almost all reopened and how that has impacted programs. And we are really excited to see that there has been, as I said, a lot of innovation at home testing and things, but that has also definitely impacted the workforce. So I will now turn it back over to Krupa.
Thank you, Emily. I'm sure that many of, if not all of the folks on the call today can relate and have experienced many of the things that are showcased in the RFI. I'm going to now go ahead and pass it on to our next presenter. That is Jessica Arizola, a Senior Program Analyst at CSTE, which is the Council of State and Territorial Epidemiologists. Jessica?
Thanks, Krupa, and thanks to everyone here today. I really appreciated having some questions in advance from those that are attending to help tailor the relevant content for what we'll be sharing. Next slide. A major question that came through was who is on the workforce team for HIV services? And I still think that this changes probably for every jurisdiction. So some major categories that we really thought that would be considered core to that HIV workforce team included disease investigation specialists, epidemiologists, health educators, medical services, community health workers, harm reduction services, behavioral health, and of course, HIV prevention. Now we recognize there's some variability, so I was hoping that if you would have anyone else on your team that you'd consider part of your workforce team, you just put in who they might be in the chat based on their professional category. So is there anyone that we're missing from these 8 boxes that is essential for your workforce team? And while you go ahead and add in those team members there, I'll just note that it's really important to think about the professional skill sets that are on the team. So thinking through the level of training and expertise and lived experience that is represented within your team. So I'm not seeing anything come in the chat box. Krupa, are you seeing anything?
Nope.
Okay. All right, well, we'll just go ahead and continue. So next slide. So as we mentioned, those represented skill sets, we really think through the function of those skills and those team members. So they really are supporting HIV prevention, HIV care, and then you have some staff that are only partially working on HIV and are really working across programs like your health educators, your community health workers, and especially grant administration. So as we're thinking about who is on your team and how do they help your team function, it's important to think about that lived experience, the diversity in training, and then also what they're bringing to their daily activities. That also varies based on the type of jurisdiction you're at. So a state agency may have more of an administrative focus or programmatic elements from their implementation, whereas a local government may be providing more direct services to clients and patients. Again, it also may have some additional levels of variation based on the governance structure for your state and local health department. Thinking about a centralized agency where your local health units are really led by employees of the state, such as South Carolina, New Mexico, and Mississippi, or a decentralized organization where the local health units are really led by employees of the local government, such as California, Washington, Missouri, New York, and Minnesota. The hybrid structure really offers a place where some local health units are led by employees of the state and others are led by employees of local government, such as Alaska, Oklahoma, Tennessee, and Pennsylvania. And then that shared structure, it really can be local led, or the locals can be led by the state. And if led by the state, or the local has authority, and if led by the local, the state then has authority for the fiscal decisions or issuing public health orders, which has become particularly relevant this last year. And that would be for jurisdictions like Florida, Georgia, and Kentucky. So all of this is to say, there is a lot of variation by jurisdiction to think about the composition of your HIV workforce team, which professions are represented, how you're engaging your community, the services and skills that they're bringing to the team, and then also the considerations of your local government structure. Next slide. So as we think about who's at the table, we also want to think about how many are needed. And so as we think through in more depth about the enumeration component, you have to consider not only the number, but that, again, that professional diversity of skills needed and that real world experience. Some of that can be caught in advance, but it's really helpful to think through this in a systematic manner. And I'll provide an example here. Next slide. So for our epidemiology workforce, we have experience identifying the different types of epidemiologists and those number of positions filled to really think through how many more workers are needed. And the basis of that really is starting, well, how many do we currently have? So I would encourage you, as you're trying to grapple with how many workers are needed for your team, think through by category or position type on who's on your team. Once you have that list, identify how many of those positions are currently filled, how many are vacant, and then kind of think of your total now current positions that are within that team. And then once you have that, that really provides that solid platform to think forward of, well, how many more are needed? Next slide. So as we think about identifying the ideal workforce size, this makes a lot of people really uncomfortable to think beyond what is currently there. We can always say, yes, we need more workers, we don't have enough staff, but to get down to that nitty-gritty of which team members you need more of and how many more is really an art to the science base that we're all more accustomed to. So we really want to think through about the ideal total numbers for existing services and in the future as public health transforms to achieve the vision. So as you might go through this exercise, you could think, okay, I've identified who's on my team. I already know from the previous slide how many current positions I have. Now, for each of these team member categories, how many more additional workers do I need to support my current activities? So whether that's, where you currently have gaps in staffing, you have vacancies, you're looking for additional support because you're unable to meet the activity demand, that's where you would add that. This third column to the right of the who would then think about your EHE goals and your overall vision for HIV services and prevention within your community. So this is taking it even one step further, thinking, okay, so we know how many we have, we know how many we need to better do the activities we currently have, and now we're working towards these broader goals, and we need to this many more staff to support these goals and really make a difference. And sometimes this can be complex when you think about balancing it with the budget. So think through and I would recommend overestimate a little bit of how many workers you might need to support it, and then balance it back with your budget at the end of the day. Additionally, you can consider, we are used to working in this environment now quote unquote a public health 2.0. And as we enter into this public health 3.0 era of public health transformation, how we do the work is going to transform. And the future of public health work, including the HIV workforce, is going to evolve and look different. So we may need to estimate a little bit higher that we're going to be more engaged in our communities, delivering more services, and doing more cross collaboration with other disciplines and organizations that we can really make those outreach efforts count and engage the community. So once you've kind of gone through and completed the enumeration there, you can sum across the columns and get your ideal total number of positions. And again, this is not an exact number, it's a little bit of an art, but it will give you at least that foundation to think about where you are and what you need to get where you want to go. Next slide, please. So as we think about getting to that ideal state, there's lots of strategies for that in between, from where you are now to where you want to go. And this can be true for jurisdictions that do have EHE funding, and then those that haven't received any supplemental funding at this time. In this juncture, in the current political state and influence and funding influx for public health, there's a lot of opportunities for collaboration, skill training, and really working through together and learning together as a public health culture going forward. So as you think about getting to where you want to go, you'll want to consider prioritizing your programmatic needs. Where are your needs today? Where can you start? And thinking about then addressing where you're wanting to go. Engaging the community partners, whether it's through funded CBOs or working with academic institutions, but really reaching out to those that have other areas of expertise that you can leverage to support your work, and also thinking about, as you do scale up your workforce, for hiring and recruitment. It'll be essential to keep those roots deep in the community and really hiring to ensure that the workforce that you're bringing in is reflective of the communities you are serving. Additionally, you'll want to consider the required skills and experiences. And I've heard multiple times, and it's not just for the HIV workforce, the challenges of the HR hiring requirements and how some requirements serve as barriers to really getting those ideal candidates in the door. And so part of this will be some policy discussion and working with your leaders and your organizations to have those conversations about the needs for those workforce to really reflect the needs of the programs being delivered, as well as engaging the stakeholders and end users that we're trying to serve. But that is definitely a tougher conversation to have. So as you think about scaling up your workforce to really bring on your team and have your bench loaded, ready to go, you can consider various staffing models. So you can think about strategic placement of staff to eliminate some different silos across different program areas and ensure some coordination of services as well as skill sets and professional expertise. You can also think about leveraging your agency and individual strengths. So if you have a really great data scientist over on the influenza team, maybe just having a working lunch or figure out a more structured way for them to share their experience and train some of the HIV staff, but really thinking beyond those that you normally work with and learning from those across your agency and within your community. Additionally, there might be some opportunities to partner with local academic institutions to offer training student experiences. So whether or not you can partner with them to facilitate internships or even partner with, say, a class on evaluation and do a real life application to assist with some project needs that you may have. Similarly, with a community needs assessment, that might be a great opportunity to engage nursing students or health behavior, health education students, and really just exposing students to public health practice, but also to really get some hands on deck and help you meet your programmatic deliverables. And really, at the end of the day, as we're looking to scale up the workforce and meet workforce needs, it really comes down to peer learning and creating that community of practice within your agency to promote cross-training, of course, but also awareness of what everyone is doing and how you can help each other. And this hopefully will facilitate a culture of technical assistance with the agency. We expect in the next 6 months to 2 years, there'll be an influx of public health workers to the agency. And I'm sure most will be eager to learn new things, but we'll also really need to leverage those that have experience at the health department to share from their experience and institutional knowledge that will really ensure that the skills and training received in classroom and real life will translate into effective public health practice. So with that, next slide, and that is all I had.
Thank you, Jessica. These are some really great points and things for folks to think about as they start thinking about how to define their HIV workforce within their jurisdictions. One thing to note is for folks who have received EHE funding, there have been a lot of new positions and a lot of new job descriptions that have come out. And so to also consider that when you're thinking about defining your HIV workforce. Also to keep in mind that as you are implementing your EHE plans and as things change within the community, that you are reviewing and revising your plans and your strategies and activities related to HIV workforce. Next, we have our final presenter for today. Presenting today on behalf of Mecklenburg County is Patrick Robinson, Research Professor at the Academy for Population Health Innovation at the University of North Carolina, Charlotte. Renate Noko, Senior Health Manager for Ending the HIV Epidemic in Mecklenburg County, is also with us today and will be available to answer questions at the end of the presentation. So I will turn it over now to Patrick.
Well, thank you, and hello, everybody. Before I jump into my presentation for this afternoon, I do want to thank and mention a couple of people. First, Renate Noko, who of course is, we work in what I think is a very effective partnership, kind of like Dr. Arizola mentioned, a relationship between the academic side and the practice side of public health. And that's what our organization, AFI, Academy for Population Health Innovation, is all about. Secondly, I want to acknowledge up front Dr. Claire Schuch, who was a key person in pulling these data together. The two of us worked closely with Ms. Noko in doing this assessment and then ultimately bringing it all to you. So next slide, if you will. I probably don't have to tell anybody here at this webinar that there is a looming national HIV workforce shortage. There have been a number of publications around this issue, including a couple cited at the bottom here. And we recognize that nationally, there's a developing shortage of qualified medical treaters. And we're also seeing a steady increase in the number of persons living with HIV as lifespan is increased, as therapy is improved. And unfortunately, in many instances, particularly the southern United States and our southeast, where new cases, new diagnoses of HIV are not dropping like we hoped they would, and like we've seen in other parts of the country. Thirdly, the so-called silver tsunami, a term coined in a presentation at a recent CROI meeting, describes the increasing medical care requirements of persons living with HIV as they begin to age. Finally, I want to mention that, of course, this pending crisis has been identified and needs to be addressed. But I also want to bring to your attention, click please. There we go. An expression that was first made popular in the ecological discussions of the early 70s, think globally, act locally. And what we've seen, I think, are some very nice investigations internationally, nationally, and even regionally of the HIV workforce shortage. But for us to act in an area where we have influence, I think we need to have the same information in our local jurisdictions. For example, in Mecklenburg County, Charlotte, North Carolina. So next slide, please. This, once again, is familiar, I'm sure, to everybody in the audience. This is a representation of the Southern HIV epidemic. And I want to point out where our locally is. We, of course, are in Central South North Carolina. So if you'll click. Okay, that's where we are. And to give you a close-up, click again. And once more, that's us right there. That's our county. Charlotte, Mecklenburg County is a large, actually Charlotte is the second largest city in the Southeast. Yes, second largest city in the Southeast, and one of the more 15th most populous cities in the country. And so on the next slide, we are representative and suffering from the HIV epidemic in the South. And this representation here shows you what our situation is. In the state, we have by far and away the most frequent number of new diagnoses and the largest number of persons living with HIV. It is substantially larger than the South region as a whole, and of course larger than the United States as a whole. So next slide, please. We are unfortunately a representative of the Southern epidemic in many ways. We are a rapidly growing metropolitan area of over 1.1 million people and continuing to grow rapidly. It's a jurisdiction of great diversity. We have white and black members of our community, rapidly growing Hispanic population, and representation of other ethnicities and countries of origin, such as South Asia and Africa. We have a great variety of race and ethnicity, as I mentioned, but we also have a diversity and disparity in economic opportunities. At the upper end of the scale, Charlotte is a financially advancing city, but Charlotte itself remains at the very bottom in terms of upward mobility. So persons of poor economic opportunity don't move up in their economic opportunities during their life very well. We have, as many other cities, we have a housing crisis. We are considerably underbuilt for the number of people we have, and many people are homeless or on the edge, on the verge of homelessness. And although our drug use issues are not tremendously great at the moment, we are seeing an increase in substance use in our area. So I think in many ways we are representative of the Southern epidemic. Next, please. So with all of this in mind, and with the goal of understanding what our workforce workforce capacity is, and how we need to respond to it, where we need to respond to it, we put together an analysis of our HIV workforce in Mecklenburg County. And this was in response to planning for ending the HIV epidemic. So this was a little bit of commercial here. This was funded by a subaward from the CDC planning grant that the county received, and therefore we decided that we needed to assess the size and the characteristics of our workforce, and perhaps more importantly, project future workforce needs for the coming 5 and 10-year period. Next, please. We took a two-part approach to this, and in truth, I think there are probably 3 parts that we should have taken an approach to. First, we were looking at HIV medical treaters, prescribers, basically. And we approached that with one type of analysis. And secondly, we wanted to look at the HIV service agencies and organizations, those within Mecklenburg County that provided specific direct HIV services such as testing, pre-exposure prophylaxis, either pre-exposure prophylaxis treatment or access to it, education and outreach, and case management. The third component we're working on rather separately, and don't have it well enough developed yet to really roll it out for you, but the third one is our PrEP providers in the county. So I'm not going to mention that today, but happy to address questions about it later if they come up. So in the next slide, we started out by finding a practical and rapid method of identifying our HIV medical treaters. Our time frame was limited, our resources were limited, but we wanted to have a comprehensive look at who our medical treaters were in the county. So we made the assumption that anybody who was a medical treater, at least by our definition, was a person who would be prescribing antiretroviral treatment for the treatment of HIV. The other part of this, the other serendipitous circumstance, is that we had been working with an organization now for a couple of years on prescription claims data sets. And we thought that that was the most expeditious way and thorough way to identify HIV medical treaters in Mecklenburg County. Next slide, next click, please. So we worked with PRA Health Sciences, which is a data aggregation based company among a variety of other things, but we work with them with aggregated health data, and they provided to us summarized data sets for pharmacy claims for antiretroviral medication. Now, each prescription writer of combination drug antiretroviral medication is captured by PRA uniquely and anonymously with an anonymous code. So we asked them to provide some summaries of these data for us. Next, please. Because we were focusing on treatment rather than PrEP, We excluded specific regimens that you're probably all familiar with that are exclusive to PrEP. We also excluded regimens that contain what look like antiretroviral drugs but are actually used for treatment of hepatitis B. And then because, as we learned, not all gastroenterologists who treat hepatitis B necessarily follow precisely the regimens that we were excluding, we also ended up excluding GI physicians from our population. We also found that when we were looking for these prescription writers, that there was quite a plethora of them who wrote maybe one or possibly two prescriptions in the prior 6 months. So we assumed that they were not the HIV medical treaters that we were looking for, that they were just a one-off, perhaps somebody covering a prescription for a partner, or as we found in many cases, an ER physician who was starting or refilling somebody's prescription who happened to come into the ER and was not seeing them long-term. So those were the exclusions from all of the antiretroviral treatment writers that we had summarized. In terms of projecting our future population of treaters, we also made the assumption that on the average, they would be retiring at age 65. And we'll circle back to that in a few minutes and so you can see why that was important. Next, please. These data were aggregated for us, of course, by the number of treaters, by gender, specialty, prescriber type, age group, and what was pretty interesting to us was the practice zip code, where these treaters were practicing their treatment. Next, please. So, yes, this was the illustration of the distribution of the prescribers. And we grouped them according to the number of prescriptions they had written in the prior 6 months. And we found this huge number that were writing maybe one or two prescriptions. So we eliminated those, as I mentioned. And on the next slide, you'll see what happens when we eliminate those. All of the other numbers above the bars remain the same. But we also, when we did this, we found that all of the ER doctors disappeared from our list, which made sense to us. And there were a few kind of other prescribers that also made sense that they would be one-off and not our experienced HIV medical treaters. We saw quite a range among these 56, and it was 56 providers that we ultimately zeroed in on as being HIV medical treaters. We see quite a range from a few prescriptions in the prior 6 months to over 200 prescriptions by some individuals. So the amount of HIV treatment varied quite a bit, but among the 56 providers. Okay, next, please. Most of the providers were family practice, family medicine, and doing primary care. Next most frequently were infectious disease specialists, and then kind of middling were internists, which I found a little surprising. I would have expected a greater proportion. And then we had a few in the other category, and we had in nursing and related categories representing nurse practitioners and the like. And you'll see down here at the bottom that we identified of these prescription writers, 92% were physicians, and approximately 7% were PAs, and a little less than 2% were nurse practitioners. Now this was rewarding for us to see, because it also resembled quite a bit the breakdown that Boyd Gilman saw in a report that he made on the national basis from a number of years ago. So this consistency with his data told us we were on the right track. Next, please. This was interesting to us and not entirely surprising. This is the distribution of practice locations within Mecklenburg County for these providers. And you'll see this map in the center here, this odd-shaped map with kind of the light yellow at the top and the bottom, and the green and the around the edges, and then in the middle, the darker green. This represents Mecklenburg County. The darker the green, the higher the prevalence of HIV is among people living in those zip codes. The distribution of providers was not particularly centered in the high need areas, but tended to be, the cluster that you see in the middle tend to be around the central hospital zone in the town. And you'll see scattering of providers elsewhere throughout the county. So not incredibly closely clustered to where the greatest need is, and not quite sure what that means in terms of availability of services. Okay, next slide, please. Now, this is where it gets interesting. We have providers grouped according to their age, and this is their current age as collected from the data set that we've been working with. And you'll notice that there's a substantial number that are in this 55 to less than 60 years age group, but not necessarily a small number in the 60 years and above. So if we think about the age of retirement being age 65, these two red bars on the right will essentially be retired out in the next, well, almost 5 years, by 2025. If we look 10 years further, by 2030, then everybody in the yellow bar and the two red bars are likely to have retired out of practice. This is a substantial proportion of our currently practicing HIV medical treaters. Next, please. So we're projecting that a little over 30% will retire by 2025, and about 45% of our current providers will be retiring by 2030. Next. Now, remember the high prescribers. We have 11 practitioners in our community that have prescribed for 200 or more unique patients in the prior 6 months from this survey, this study. Most of them are men, male, and 3 have unknown gender. The practice distribution, more than half are infectious disease specialists, family medicine and internal medicine follow. And these high prescribers are found most frequently in the 55 to 60-year-old age group. None of them were young prescribers. None of them were less than age 45, and all of them were physicians. So what this means is not only are we going to see a decrease in the number of providers out of our current cohort, but these are going to be the high prescribers for the most part. So perhaps more impact on the availability of HIV care for the patients in our county. Next, please. So that's the first part of the prediction. The second part of the prediction is what's going to happen to the number of persons living with HIV in our county here. And unfortunately, the numbers kind of run together across the bottom, but this is on the left-hand side, the numbers of persons living with HIV for the years 2014 through 2019, and then predictions for 2020 through 2030. Now, this is prediction, so there's some confidence or lack of confidence in this prediction. So you'll see the two light dotted lines representing the 95% confidence interval about what our prediction is for the number of persons living with HIV in the county over the next 10 years or so. So we use that ultimately in doing a sensitivity analysis, but we can get to that another time. What we did use, though, is we projected the number of people who would be living with HIV in the county in 2020, 2025, and 2030. And you see at 2030, we're predicting an increase up to about 10,000 persons living with HIV. Next, please. Okay, so here is where we pull that all together. This table in the vertical columns represents the data for 2020, 2025, and 2030. Across the first row, we see our current cohort of 56 people, 56 medical treaters. And those we predict will be dropping off through retirement for 2025 and 2030. So we get down to about 33 of the original 56 remaining in 2030. You'll see the next line down is our estimation of loss from the cohort. And then the third line down are the numbers that you just saw on that graph, the persons living with HIV in each of those years projected to be living with HIV in Mecklenburg County. Now, the next line, treaters per 1,000 persons living with HIV. We calculated the ratio of treaters to 1,000 persons for 2020. You see this number 7.68 treaters per 1,000 persons living with HIV. We assumed that we wanted to at least keep the accessibility constant over the next 10 years. So we carried that 7.68 across both of our future prediction periods. This allowed us then to calculate the number of treaters that we would need to continue to measure this, to continue to keep this ratio the same, to continue the same availability of practitioners per number of persons with HIV. And you'll see that it goes up to 67 and then 79 approximately. And the bottom line, which you see circled in red here, these are the numbers of new treaters we project that we will need to maintain just our current status, just the current ratio of treaters per 1,000 persons living with HIV. Next, please. All right, so you'll see that if we take retirement, the numbers who will need to be replaced, and we add to that the number of persons needed to cover this increasing persons living with HIV in the county. By 2025, we need to have a 32% increase from our current workforce to what would be needed in 2025, just to maintain status quo. By 2030, 82%. That is really remarkable, and I think disturbed a lot of us when we looked at this number. Keep in mind, of course, that this does not account for the increasing medical complexity of persons living with HIV who will be aging. So this is kind of a bottom line, bare bottom estimation of what would be needed. Next, please. Now, there's some caveats to keep in mind. We could not factor in any loss through non-retirement mechanisms, such as people dropping out of practice to do another kind of medicine. We have had no mechanism thus far to predict the entry of new persons who are medical treaters coming into the workforce. And then finally, one other limitation is that antiretroviral treatment prescriptions actually may not fully define our persons who are HIV medical treaters, because oftentimes prescriptions are signed off by physicians for nurse practitioners or PAs. So the nurse practitioners and PAs may be underrepresented in this analysis. Next, please. So moving on, I want to talk a bit about our other component, and that is assessing the HIV service workforce assessment. We wanted to look at the workforce from organizations and agencies in the community that provided direct HIV services. And we were not looking for antiretroviral treatment in this group, but we were looking for other important services. Next, please. So we had an extensive effort to reach out and identify those agencies, and we did it through the health department's connection with many of the agencies, the Getting to Zero Mecklenburg County, which is our planning group, a very large, very effective countywide planning group that includes many people from agencies. MedLink is another medical linking organization, and then of course the medical providers that we were aware of. In addition, we did snowball recruitment, chain recruitment, so that when we recruited an organization, we asked the person that we were talking to about other organizations that they knew of that may not have been on our list. And we did this over and over and over, developing the list further and further until we exhausted all of the leads in the county. So we don't think we missed much, if any, agencies or organizations that provide HIV services. Next, please. At that point, we asked the managers, the senior managers from these organizations and from the health department, which provides similar services, to complete a survey about the services they provide, their workforce size and its characteristics, and current and anticipated workforce needs. Next, please. We identified 18 agencies, and this included the health department, which does provide education, outreach, linkage to PrEP, many of these particular services. We found that 11 of these organizations were Ryan White organizations. 5 focused exclusively on HIV and needs of persons living with HIV. And then among these 18 organizations, 11 of them served over 200 persons living with HIV in the past 12 months. So very engaged, very involved. Next, please. And this is a rundown of the services and kind of relative numbers of the agencies that provide these services. So everybody provided education and outreach. Almost everybody provided HIV testing. A fairly substantial proportion provided case management and either PrEP services or linkage to PrEP services. And what surprised us is this overlap that we had a number of them that actually do provide treatment as well, HIV antiretroviral treatment. And then finally, there's some other categories which include PEP referrals, PrEP referrals, behavioral medicine, mental health referrals, and syringe access. Next. Now, this is kind of interesting here because these are the locations of the organizations that provide that I just talked about, providing services, and they indeed are clustered either in or very close to the areas of our county where the prevalence of HIV is the highest. So if you're talking about nearby services, I think these organizations are filling that bill quite well. You'll see a couple of outliers. They do provide services to people from the county, even though they're not physically located in the county. Next, please. Let's see, what is the distribution of the staff working in each of these areas? Most are testing or education and outreach. Case management, you'll see kind of middling, PrEP kind of middling, and treatment also not insignificant. We identified, now I call this at least 233 persons working in HIV services in the county. There's a quirk in one of the questions in the survey, which allowed sites to answer specific numbers, or in some cases, several of the sites said X number or more. So that's why the pluses are next to each of these. We know that they are at least the numbers that are displayed, and probably a few more by those sites that said at least this many. We also know that they're quite well developed staff, so that you see more than half of them have specific HIV training or certification. Next, please. The ages among the agencies and organizations tended to be younger than in the treating organizations. And you'll see here, most of them were in the 35 to 49 years age group. And so that suggests to us that they are of an age to have experience, but they're not likely to age out through retirement anyway, at least in the next few years. Next, please. This is a breakdown of the reported race and ethnicity. And we think it's important for a couple of reasons, but one of the important ones I think is the populations that these agencies and organizations serve. This mirrors reasonably well the race ethnicity distribution of HIV in our county. So we think that this at least gives the opportunity for people who are comfortable with seeing people who resemble them in this setting. So the African American Black members of these organizations are certainly available to see persons of color who are at risk. So we think this is a pretty good representation of persons who are at need of these services. Okay, next please. Gender identity, you see right here, female more than male. We had a small proportion, but not insignificant, who identified as non-binary or non-conforming. We had none, though, who identified as transgender. And that may indeed be problematic because we think we are having trouble finding our way into reaching the transgender community in our county. Next, please. Okay, let's go on. Next. So estimating the supply and demand now and in 5 years, well, of the organizations, 62% believe that their organizations meet the current workforce needs. However, when you look 5 years into the future, only 29% felt that they were fully prepared to meet the future needs. And 19% said that they were somewhat or mostly prepared. Next, please. And this is a graphic representation of, in the blue, the anticipated need over the next 5 years. So in the left-hand grouping, you'll see that 2 organizations felt that they would not have any need for new hires in the next 5 years. But on the other hand, 11 organizations felt that they needed somewhere between 2 and 5 to maintain their duties. So yes, new hires are needed. Yes, new hires are anticipated, as you see in orange. And so that's what the predictions are for the next coming years, that there will be some need, a modest need to increase staffing. Next, please. So what are the specific areas of future needs that these organizations felt they had? Case managers was at the top of the list, but also importantly, transgender staff to help with the comforture of transgender persons who need services. PrEP services, I think people are anticipating those will increase and they'll need increased staffing. And just in general, more staffing and more funding, since many of the organizations depend on outside funding, either through grants or donations, to support their HIV missions. Next, please. So in terms of the HIV medical workforce, that first group that we talked about, we see an impending crisis, a developing crisis in the workforce in the county. Unfortunately, as we've thought about this and discussed this among ourselves, our opportunity to influence increasing the workforce seems mostly out of our hands, outside of the hands of the community or the county. I mean, training for future clinicians, medical practitioners, PAs, NPs, that often creates the direction, the area of practice that these practitioners, these potential treaters will see before they get out and start practicing on their own. So that means medical school, PA school, nurse practitioner program, curricula to encourage people to join the HIV treating workforce. And that we don't see that we have an easy way to influence that. Next. We think increasing involvement of nurse practitioners, PAs, and perhaps even pharmacists has been seen in certain settings, may help this workforce deficit in the future. But once again, it depends on training programs and mentorship. Maybe the mentorship is an opportunity to intervene. It also depends, we think, state level and national level certification or licensure. Again, not really in the purview of the county to influence. And then next, increased financial incentives. I don't know whether you've seen, but is it, MedPage, I believe, periodically does assessments of income, and infectious disease and HIV practitioners are among the poorer paid professionals in medical practice. And next, conclusions for the HIV workforce, services workforce. Currently, I think we're fairly sanguine that staff generally meets current needs. However, there's going to be need to expand for the future. And that expansion is going to require resources and specifically funded programs, which is where these organizations tend to have to go to expand their staff. Next. And then finally, very importantly, both on the HIV treater side and the services side, these practitioners and these organizations need to respond to the diversity of persons living with HIV, not only to reflect kind of physically and socially the patients that they're caring for, but also to be sensitive to the needs of people of diverse backgrounds. And I believe that's it. Oh, yes, forgot an important point here. Especially in the HIV services workforce, people have to face the challenges that their clients are facing. How can they help them with financial difficulties? How can they help them with housing shortages? How can they help them with mental health, either directly by providing it or by referral to what in our area certainly is a very small mental health treatment opportunity. And then, of course, access to health care. So these are some of the challenges that people in the HIV services workforce face, and they take time, which will consume the time that they have to deal with their clients. Okay, so I do think that's the last bullet. And I want to thank you for listening. And one more click will acknowledge a number of people and organizations that were part of this. And I want to thank once again, especially Ms. Renata Noko for her encouraging us and helping us and providing lots of input and direction in this aspect of needs assessment in our county. So thank you.
Thank you, Patrick. That was great. Really useful information. You can put your questions into the chat box or use the Q&A feature to ask your questions. We did have one question during the presentations, and I will open it up to anyone who would like to answer or share. The question is, how are organizations preparing long-term assisted living and care facilities for this influx of elders who are people living with HIV, both in terms of medical needs and competency of their identity as people living with HIV, such as combating stigma and bullying, for example?
Wow, that's an outstanding question, and my answer to that is not at all, as far as I know. It's unfortunate, but I mean, I am certainly not aware of preparations for capacity at long-term care facilities, or competence in HIV care, or even diversity competence. I would certainly welcome anybody who does have that information to speak up, because I'm not aware of it happening.
Thank you.
Can we hear by the phone? I can't. Can you hear by the phone?
Yes, we can hear you.
Oh, sorry. So, Jenny Kane in Indianapolis, Indiana. Did you take into account when I saw the slide that shows how the numbers are increasing each year from 2025 to 2050, that you're going to have a larger number of people living with HIV/AIDS? Did you take into account PrEP and its impact on your numbers?
What we did was we looked at experience thus far and used that to project future experience. Now, the shortcoming there that I think you're getting at is that if we are effective in preventing more infections through PrEP, or U=U strategies, then maybe that increase won't rise quite so much as we projected. And if we get really good by 2030, it may be almost flat. So we did not do that in our main calculation. We did do a sensitivity analysis that looked at the upper and the lower 95% bounds. And surprisingly enough, it didn't change the story. It changed the numbers somewhat. So if the numbers of persons living with HIV flattens out as we get more effective in preventing new cases, the numbers won't be quite as large, but they're still really quite substantial, and not anything that I think we're prepared to address in Mecklenburg County.
Gotcha. Okay, thank you. I have other questions if no one pipes in.
Yes, please ask your questions.
So one of the things that came up with the COVID was how many of our HIV patients ended up being homeless, from a housing standpoint. So while we're going to also have that workforce capacity decreased, and I think someone was talking about how do we take care of the seniors from a bullying standpoint, but how do we take care of our aging clients that may not have housing? And I think it takes some special training related to those patients from a case management standpoint, or taking care of their needs that's not so much medical as it is social needs.
Yeah, absolutely.
Yeah, I think that's a good point, a very important point, and yet another area that we're stressed out about in Mecklenburg County because of our underhousing. And as all of you know, so I'm telling you what you already know, is that people living with HIV who have housing issues, who have food insecurity issues, on top of their list is not necessarily taking care of their HIV. On top of their list is where they're going to stay out of the weather, where they're going to get their next bit of food. So those are critical issues that we're just, we don't feel like we're doing a very good job in the county in general with those issues. Maybe Renata, you have some comments on that as well. I mean, you certainly are very familiar with our situation in the county.
You mean in regards to housing
Yes.
for the elderly? Yeah. So we've had those conversations back and forth, but I know that we generally here in Mecklenburg County already have a very serious housing issue, housing shortages, and things like that. We have a part of our department that gets HOPWA funding, but it's quite a challenge because we don't even within in-house Mecklenburg County have the expertise. I think there's an organization, the Carolinas Care Partnerships, that does more of the coordination with housing. But I think the bigger issue and problem that we have here within Mecklenburg County of Charlotte is just that shortage with housing, affordable housing overall. But it's definitely in conversations in the works, and we do recognize the problem and just, continue to have conversations to see how we could address that.
Julie, one other question that came up. I know you looked at a number of infectious disease providers and you looked at internal medicine providers and family practice providers. Do you see more of an increase now in our internal medicine and family practitioners to do more care? Is that training going to increase when we get to 25 and 2030 so that you won't always need a specialist in terms of taking care? Will it become more mainstreamed that we're having more? Because it seems like the treatment, even though we got tons of different regimens, it is kind of more simplified. It's not as complicated, I think, for mainstream providers now to take on the responsibility of managing HIV patients.
Yeah, I think that is a push nationally to train more PAs and NPs and family physicians to provide care. And it's something that we've been talking about with our community group as well. How we do that, though, is as Dr. Robinson mentioned, a lot of this is outside our control. But I guess, using the forces that we have within our community, some of our prominent providers who can also bring the case to the North Carolina Medical Board to sort of think ways to ensure that NPs and PAs and family care physicians, not necessarily infectious disease providers, have that type of training that they need in order to provide the care for HIV clients, as well as do the prescriptions and things like that. So yes, that is we've been talking about that, and we're pushing forward for NPs and other general clinicians to get the training that they need to provide care and treatment.
I think that's important. Maybe you can partner with schools of nursing, schools of physician assistants, some type of collaboration in terms of producing folks who specialize in this area.
Absolutely.
Any other questions? Please feel free to unmute yourself and ask your question, or you can put them in the chat or use the question and answer feature.
My last question, and I'll shut up, in Indianapolis. What are we doing? How have we fared now with integrating HIV services in our fairly qualified community health centers? I know at one point, it was about 4 or 5 years ago, a significant amount of dollars were given to fairly qualified community health centers if they provided HIV services. for our federally qualified community health centers, and I heard that initial funding happened, and then I kind of didn't hardly hear anything anymore. And so I'm wondering if that's something we've got to continue to really pushing to make sure at least in those clinics across the country, and we've got like 24, 25 clinics, federally qualified community health centers just in Indianapolis alone, what's being done to continue to push from a capacity standpoint, being able to provide clinical services for our HIV clients. I don't know, someone could do a study or a query to just see what's happening from the Bureau of Primary Care.
Sorry, can you repeat the question?
So what I'm interested in, we're talking about workforce capacity, and where are we going to be in 25? What does it look like in 2030? And it looks like, because people are getting, we're getting old. I'm old, okay, and we're going to retire soon. Maybe in the next 5 years. Where's that new crop of providers going to come from? And one area are in our federally qualified community health centers, where they're going to be around, and they provide services for a lot of our clients who may be low income, don't have the always the necessary insurance. Even Obama cost a lot of money to pay for those premiums. So what does it look like that they are taking care of and providing HIV services? The Bureau of Primary Care 5 years ago gave tons of money to primary care centers if they initiated and provided HIV services. And then you really haven't heard any more from them lately in terms of their capability. So I'm just saying it would be nice if there was some kind of study or query done by the Bureau of Primary Care to say, of all of your federally qualified community health centers that receive funding, federal funding each year, which of your centers still provide HIV care? And if a significant percentage is not, one of the things we can encourage the federal government is, we want to end this HIV epidemic. What are you doing to provide resources in order to provide HIV resources in your bureaus of primary care, your federally qualified community health centers?
Well, I can't speak nationally, but in Mecklenburg County, we do have a couple of FQHCs that are providing HIV care. I don't know their specific numbers, but I do know
Okay.
of their commitment to provide it. And so the effort is there, and care is being provided. I don't know how to quantify it, um, uh, but that's our experience here.
That
Okay.
is,
I'm just
it
saying that
utilize-
you've captured what you think is our workforce capacity. I just want to know, does that include the providers in our fairly qualified community health centers?
Oh yeah. Our FQHCs were included in the agency and service organizations part of the assessment, and the treaters that are working in those FQHCs would indeed have been captured in the HIV medical treaters analysis. So
Okay, thank you.
it's happening.
Okay, I appreciate that. I was just unsure. Thank you.
We have 2 questions that just came in. The first question is, are you or anyone using public health detailing to engage clinicians and expand treaters? And the second question is, how are people engaging and working with the AETCs on workforce capacity and training related to EHE and general HIV planning strategies?
Can you give that last question? I couldn't quite understand it. Repeat
Sure.
that last question.
Yeah, the second part of the question is, how are people engaging and working with the AETCs on workforce capacity and training related to ending the HIV epidemic, or just general HIV planning strategies?
Well, for the first question, and again, Renata may want to comment on this. We have the larger we, the planning group in Mecklenburg County have talked about possibility of public health detailing, and the health department did indeed have, and I believe still has, a position that has that as part of the person's responsibility for encouraging PrEP care. Now, I'm not sure that the same is being done for treatment necessarily, and certainly the bigger push for encouraging knowledge of and practitioners getting into treatment of HIV is primarily been part of the hospital organizations, the large healthcare organizations in our community.
Thank you. Is anyone on the call? Have you worked with the AETCs, your local AETCs, on any workforce capacity or training?
So this is Jenny Kane in Indianapolis. We work with our ATECs on doing training and education for our providers. And I'm I'm co-chair for HIV for the National Medical Association. So we have been doing training on PrEP for regional trainings on PrEP for our providers, trying to encourage them to take on the management of PrEP in their practices if they're not already doing it. So we're trying to do a combination of both in Indianapolis. And doing, because of this end the HIV epidemic, of course, going to a lot of our civic organizations, just our churches and different places like that, having town meetings, trying to tell our clients, hey, the service is available. Please encourage PrEP. And we work with our Black Pride organizations to encourage that message out too with their participants. Trying to do a better outreach with our minorities, because our rates of uptake is way much lower than our white counterpart patients.
Yeah, thank you for that. I do want to be mindful of the time. So I thank you all for these wonderful questions. And if you have additional questions, please reach out and we can send out the answers from our speakers with the recording. So I just want to move on and notify everyone of some upcoming webinars and meetings that we have. This first webinar today is a part of a series. So the second HIV workforce webinar will take place on June 30th. We'll be sending out the registration information for that soon. Also, the CDC virtual recipient meeting for EHE jurisdictions will take place from July 13th through the 15th. And CDC and NASDAD will be hosting an EHE, Ending the HIV Epidemic Technical Assistance meeting from August 3rd through the 5th. Next slide. So just a final thank you to all of our presenters today, as well as our partners at the CDC. Here's the contact information for all of our speakers, as well as those of us here at NASDAD. Please do reach out for technical assistance related to HIV workforce through the CEBA system at cdc.gov. We will be sending out the recording of this webinar within the next 2 weeks. And yeah, I think that's all for today. Thank you so much for joining us, and we hope to see you at the next webinar.
Thanks for having the webinar. Thank you.
Thank you.